Hello, everyone, and welcome to MRA's monthly presentation for education. Today, we are going to be talking about coding dementia, encephalopathy, and delirium diagnoses. Here is our disclaimer. Every reasonable effort has been taken to ensure that the educational information provided in this presentation is accurate and useful. Applying best practice solutions and achieving results will vary in each hospital facility situation. A thorough individual review of the information is recommended and to establish individual facility guidelines. MRA does not guarantee the contents of this material and denies any implied guarantee of appropriateness of this material for any specific purpose. MRA is not liable or responsible for any loss or damage caused by the information presented in this material, including but not limited to any loss of revenue, interruption of service, loss of business, or indirect damages resulting from the use of this presentation. Furthermore, MRA does not guarantee that the content of this material will restrict disputes or differences of opinion with third-party payers, Medicare or otherwise, as to the specific dollar amount that is to be paid to the service provider. Copying, distributing, recreating, or any other unauthorized use of the content in these slides without the express written consent of medical record associates is strictly prohibited. My name is Mary Chelucci, and I have been in HIM for over 35 years. Currently, I work as a project manager for MRA, and I've done many jobs in health information. I started as a file clerk in college, and I've been a trauma registrar, supervisor, as well as medical records coordinator. I'm an RHIA, CCS, and an AHIMA-approved Train the Trainer. So we are going to be talking today about coding dementia, encephalopathy, and delirium. And we will also be coding a few scenarios. So have your ICD-10 CM books handy so you can code with me. So today we will be talking about the definitions and types of dementia, definitions and types of encephalopathy, definition of delirium, confusion, and altered mental status, or AMS. We're going to review coding guidelines and conventions, including Coding Clinic and the official coding guidelines. We're going to talk about medications and treatments associated with dementia, encephalopathy, and delirium. So on our first topic, we will be talking about dementia. And there are many types of dementia, and we will be discussing the most common types. There are more types than what we will discuss here today. And you can see the other types in your ICD-10 CM index and tabular. So what is dementia? Dementia refers to a decline in cognitive functioning to the point where it interferes with daily life. Dementia is a nonspecific diagnosis that includes a large range of symptoms and manifestations. So let's talk about some symptoms of dementia. Experiencing memory loss, poor judgment and confusion, difficulty speaking and understanding and expressing thought or reading and writing, wandering and getting lost in a familiar neighborhood, trouble handling money, responsibility, and paying bills, repeating questions, using unusual words that refer to familiar objects, taking longer to complete normal daily tasks, losing interest in normal daily activities or events, hallucinating or experiencing delusions or paranoia, acting impulsively, not caring about other people's feelings, losing balance and problems with movement. And we also have a few key facts about dementia. Dementia is a syndrome in which there is deterioration in cognitive function beyond what might be expected from the usual consequences of biological aging. Although dementia mainly affects older people, it is not an inevitable consequence of aging. Currently, more than 55 million people live with dementia worldwide, and there are nearly 10 million new cases every year. Dementia results from a variety of diseases and injuries that primarily or secondarily affect the brain. Alzheimer's disease is the most common form of dementia and may contribute to 60 to 70% of cases. Dementia is currently the 7th leading cause of death among all diseases and one of the major causes of disability and dependency among older people globally. Dementia has physical, psychological, social, and economic impacts, not only for people living with dementia, but also for their caregivers, families, and society at large. So as I had told you before, we're going to be talking today about the common types of dementia, but I wanted to include a screenshot of the coding book index for dementia to show you that there are many types beyond what we will be discussing today. So what are the common types of dementia? Alzheimer's, which is code G30 through G30.9. Frontal or frontotemporal, code G31.09. Multi-infarct, arteriosclerotic or vascular, code F01.50 through F01.51. Pre-senile or senile, code F03.90 through F03.91. Parkinson's, code G20. Lewy body, code G31.83. And dementia in HIV disease, code B20, with codes F02.80 through F02.81. So let's first start with Alzheimer's dementia, which is ICD-10-CM code G30.0. Alzheimer's disease is the most common form of dementia and is caused by the destruction of the subcortical white matter of the brain through a development of neurofibrillar tangles and amyloid plaques that eventually lead to death of the nerve cells. It is characterized by increasing loss of intellectual functioning, beginning with minor memory loss and eventually resulting in total loss of ability to function. So as you can see here, there are 4 codes for Alzheimer's. And they begin with G30.0, which is Alzheimer's with early onset. And this is for patients who present with symptoms as early as 30 years old, but it's often between the ages of 40 and 50. And myoclonus may be a distinguishing factor that is often seen in early onset. We also have G31.1, Alzheimer's with late onset. And this is the common form, which usually occurs after the age of 65. We also have G30.8, other Alzheimer's disease. And this is a code that includes any specified type of Alzheimer's that is not documented as early onset or late onset. And finally, we have G30.9, Alzheimer's disease unspecified. And this is used when the etiology cannot be identified or the type of Alzheimer's is not stated in the documentation. And you will probably find that the G30.9 is the most common code that you're going to be using because most physicians do not give you that much specificity. And remember, you cannot code the early or late onset without documentation of it by the physician or provider. So we have our first coding clinic here, and this is regarding Alzheimer's disease and dementia. And all the coding clinic references I'm showing you today are abbreviated. If you want to look at the full reference and the full question, you will have to refer to your coding clinic source. Hopefully you have access to coding clinic through your employer or encoder. This one is from first quarter 2017, pages 43 and 44. And the question is, how is Alzheimer's disease coded when the provider does not code dementia? The ICD-10-CM index directs the coder to use G30.9, Alzheimer's disease, and F02.80, dementia and other diseases classified elsewhere without behavioral disturbance. Is this correct? And the answer from Coding Clinic is, since dementia is inherent to Alzheimer's disease, it does not need to be documented by the provider separately. Dementia is a manifestation of Alzheimer's and should be coded. The G0.9 would be sequenced first, followed by the F02.80 or F02.81 if the patient has behavioral disturbance. And you may want to refer to Official Coding Guideline 1.A.13 regarding guidelines on coding manifestations of diseases. So let's move on and talk about dementia and other diseases classified elsewhere, which is an add-on code that you code with another disease. You'll use this as an accompany code. And these codes are F02.80, dementia and other disease classified elsewhere without behavioral disturbance, or F02.81, dementia and other diseases classified elsewhere with behavioral disturbance. And behavioral disturbance is considered patients who have hallucinations, paranoia, aggression, agitation, and it will have to be documented by the provider. Just because you see that a patient may be acting strangely, you cannot just assume that's considered behavioral disturbance. The physician needs to specifically document some manifestations of it. And also, when coding F03.81, there is a coding note to use an additional code Z91.83 to identify if the patient has wandering in dementia. So you can add the Z91.83 in that situation. So moving on to our next topic, which is Parkinson's dementia, Parkinsonism, and Lewy body dementia. So let's talk about what these three conditions are. Parkinson's disease is coded with G20, and it is the progressive disorder of the nervous system which typically affects middle-aged adults. It is associated with degeneration of the basal ganglia and a deficiency of the neurotransmitter dopamine. Parkinson's disease affects movement, and tremors are a well-known sign of the disease. Parkinsonism, which is also coded to G20, refers to symptoms characteristic of Parkinson's disease, such as slow movement and tremors, regardless of the cause, and is typically caused by another condition or external agent, such as drugs. Lewy body dementia, which is coded to G31.83, Lewy bodies are protein deposits that form in the nerve cells of the brain, causing the nerve cells to die. Lewy bodies can be found in patients with Parkinson's disease and Alzheimer's disease, making diagnosis difficult. Certain characteristics of Lewy body dementia not associated with Alzheimer's disease may include the inability to copy or draw, fluctuation between coherency and incoherency, especially in the early stages, visual hallucinations, and minimal issues with memory upon initial onset. So how do you code Parkinson's disease or Parkinsonism or Lewy body dementia? Parkinson's with dementia is coded with G20 and F02.8 with or without behavioral disturbance as your fifth digit. Dementia with Parkinsonism is coded with G31.83 and F02.80 or 1, with or without behavioral disturbance. And Lewy body dementia is coded with G31.83 and F02.80 or 1 with or without behavioral disturbance. And as you can see, this is a bit confusing because if you code Parkinsonism alone, it's coded to G20, but when you code dementia with Parkinsonism, it's coded to the G31.83. And I'm going to show you a copy of the coding index to show you if you do index dementia and you look under Parkinsonism, it codes to G31.83. And if you code dementia with Parkinson's disease, it codes to G20. So it's important to pay attention to the documentation because these are two different codes. And we have a coding clinic regarding this same situation, Parkinson's dementia versus Parkinsonism. And it's second quarter 2017, pages 7 and 8. And our question here is, patient is admitted with Parkinson's disease and aggressive behavior. There is some confusion as to whether to use G20 Parkinson's or G31.83 dementia with Lewy bodies. What is the code assignment for Parkinson's dementia with aggressive behavior? And the answer here is you assign code G20 Parkinson's disease and F02.81 dementia and other diseases classified elsewhere with behavioral disturbance. Now we also have another coding clinic, fourth quarter 2016, page 141. How do you code Lewy body dementia? And the answer here is code both G31.83 Lewy body dementia and F02.80 or 1 dementia and diseases classified elsewhere. There is a coding instructional note under F02.8 that states code first the underlying physiological conditions such as the G31.83 is the underlying condition and should be sequenced first. So remember your F02.8 code is a manifestation code and you want to code the underlying condition first. So let's move on to another type of dementia, which is senile or pre-senile dementia. So what is senile or pre-senile dementia? Senile dementia is the mental deterioration or loss of intellectual ability that is associated with or the characteristics of old age. Pre-senile dementia is dementia beginning in middle age and is progressing rapidly. So how do you code senile or pre-senile dementia? You will use code F03.90, which is classified as unspecified dementia without behavioral disturbance, or F03.91, unspecified dementia with behavioral disturbance. And if you look in your coding index, the diagnoses that are included in code F03 are pre-senile dementia, not otherwise specified, pre-senile psychosis, not otherwise specified, primary degenerative dementia, not otherwise specified, senile dementia, not otherwise specified, senile dementia of the depressed or paranoid type, and senile psychosis, not otherwise specified. So basically, senile and pre-senile dementia are coded identically, even though they are considered two distinct conditions. So moving on in our dementia topics, we're going to talk about multi-infarct dementia. So what is multi-infarct dementia? Multi-infarct dementia is a type of vascular dementia, and you will often see it referred to as vascular dementia. It occurs when a series of small strokes causes a loss of brain function. A stroke or infarct occurs when the blood flow to any part of the brain is interrupted or blocked. Vascular or multi-infarct dementia is the second most common form of dementia after Alzheimer's. It can be coexistent with dementia in Alzheimer's disease, dementia with Lewy bodies, or other forms of dementia, making differentiating between the types very difficult. So how do you code multi-infarct or vascular dementia? You use codes F01.50, vascular dementia without behavioral disturbance, and F01.51, or vascular dementia with behavioral disturbance. And once again, it states here that agitation is the most common behavioral disturbance, often exhibited in forms of aggression, combativeness, pacing, and wandering. Hallucinations and paranoia are common. Behavioral disturbances occur typically in the evening and may be referred to as sundowning. And I have an additional note here. When coding multi-infarct or vascular dementia, there's a coding note that states, code first the underlying physiological condition or sequela of cerebral vascular disease. So you will always want to code first those conditions, if you know them, when coding vascular or multi-infarct dementia. So let's move on to frontal or frontotemporal dementia. What is frontal or frontotemporal dementia? Frontotemporal dementia is an umbrella term for a group of brain disorders that primarily affect the frontal and temporal lobes of the brain. These areas of the brain are generally associated with personality, behavior, and language. In frontal temporal dementia, portions of these lobes shrink or atrophy. So how do you code frontal or frontotemporal dementia? You'll be using G31.09, other frontotemporal dementia, and you will add code F01.80, dementia in other diseases classified elsewhere without behavioral disturbance, or F03.81, dementia in other diseases classified elsewhere with behavioral disturbance. So last in the dementia topic, we will talk about dementia in HIV disease. So what is HIV dementia? HIV-associated dementia occurs when the HIV virus spreads to the brain. Symptoms of HIV-associated dementia include loss of memory, difficulty thinking, concentrating, and/or speaking clearly, lack of interest in activities, and gradual loss of motor skills. So how do you code HIV with dementia? You will sequence the HIV code first, which is B20, human immunodeficiency virus. And secondarily, you will add code F02.80, dementia in other diseases classified elsewhere without behavioral disturbance, or F02.81, dementia in other disease classified elsewhere with behavioral disturbance. So now let's get out our coding books, and we are going to try our first coding scenario, and I will give you a few seconds to look up the code. Our question here is, a 70-year-old male presents with increased confusion and altered mental status. Patient is agitated and aggressive. Patient has known Alzheimer's disease. Final diagnosis is Alzheimer's dementia. How would this be coded? So I'll give you a couple seconds here and you can try out coding this. Okay, our answer here would be G30.9, Alzheimer's disease unspecified, and F02.81, dementia and other diseases classified elsewhere with behavioral disturbance. And the G30.9 would be used since the onset of Alzheimer's is not documented. It's not documented as early versus late onset. And the F02.81 would be used in this case due to the agitation and aggression. So now let's move on to encephalopathy. So what is encephalopathy? Encephalopathy is a general term used to describe any disorder of cerebral function. It is a very broad term and in most cases will be preceded by various terms describing the reason, cause, or special conditions leading to the brain disorder. So let's look at some symptoms of encephalopathy. Loss of memory, reduced ability to think clearly or concentrate, drowsiness, changes in personality such as irritability, aggression, impulsive behavior, or having suicidal thoughts. Some people might also have involuntary muscle twitching, difficulty speaking, difficulty swallowing, unusual eye movements, tremor, muscle weakness, seizures, dementia, or loss of consciousness. So there are many different types of encephalopathy, and we are going to be going over those today. First, we have anoxic encephalopathy, and this is coded to G93.1, anoxic brain damage, and it refers to brain damage occurring due to lack of oxygen. Alcoholic encephalopathy is coded to G31.2, degeneration of nervous system due to alcohol. And this is a serious complication of alcoholic liver disease, usually caused by excessive drinking for several years. It results in a loss of specific brain function, damage of brain tissue caused by a thiamine deficiency. Alcoholic encephalopathy is classified to G31.2. Hepatic encephalopathy is coded to K72.90, hepatic failure unspecified without coma. And it is brain damage due to liver disease. And at the index entry failure hepatic, there are sub-entries for codes to specifically describe different etiologies and for hepatic failure with or without coma. Hepatic encephalopathy is not synonymous with hepatic coma. The default for hepatic failure is without coma. So just because somebody has hepatic encephalopathy, it does not assume a coma is involved. That would have to be documented. We also have metabolic encephalopathy. And this is coded to G93.41. And it is temporary or permanent damage to the brain due to lack of glucose, oxygen, or other metabolic agent, or caused by organ dysfunction. Symptoms include an altered state of consciousness, usually characterized by delirium, confusion or agitation, and changes in behavior or personality. There can also be muscle stiffness or rigidity, tremor, stupor, or coma. Symptoms can develop quickly and may resolve when the condition is reversed. And code G93.41 also includes septic encephalopathy. So if you see the term septic encephalopathy, that would code to G93.41. We also have toxic encephalopathy. This is a degenerative neurological disorder caused by exposure to toxic substances or as an adverse effect of medication. It is characterized by an altered mental status, and symptoms can include memory loss, small personality changes, lack of concentration, involuntary movements, nausea, fatigue, seizures, arm strength problems, and depression. ICD-10-CM classifies unspecified toxic encephalopathy to code G92.9, while toxic metabolic encephalopathy is classified to G92.8, other toxic encephalopathy. The appropriate reporting and sequencing of toxic encephalopathy include due to drugs is based on whether the drug toxicity qualifies as an adverse effect or poisoning. When coding an adverse effect of a drug that has been correctly prescribed and properly administered, assign the appropriate code for the nature of the adverse effect, followed by the appropriate code for the adverse effect of the drug, which is in codes T36 through T50. The code for the drug will have a fifth or sixth character, 5, to indicate adverse effect. If toxic encephalopathy is due to poisoning from a toxic agent, a code from category T51 through T65 is assigned first to identify the causative toxic agent. And code G92.9 is assigned for unspecified toxic encephalopathy. So basically they're saying here to make sure you know, was the drug appropriately administered and prescribed, which would be an adverse effect, or was it a poisoning, and that would be coded differently with your T codes. Wernicke's encephalopathy involves damage to the central nervous system and peripheral nervous system and is caused by the disorders of the liver such as cirrhosis, hepatitis, malnutrition, and conditions in which blood circulation bypasses the liver entirely. The symptoms can range from mild to severe and consist of various neurological symptoms, including changes in consciousness, reflexes, and behavior. And you would code E51.2 for Wernicke's encephalopathy. Moving on, we have encephalopathy associated with cerebral vascular accident and stroke. And this code would be code G93.49, other encephalopathy, in addition to the codes for cerebral vascular accident or stroke. Please note code G93.49, other encephalopathy, is assigned when encephalopathy is linked to a condition such as encephalopathy due to a urinary tract infection. But a specific encephalopathy, such as metabolic, toxic, or hypertensive, is not documented. So this code can be used other than with cerebral vascular accident if it's linked to another condition, is basically what they are saying here. But as long as it's not specified as metabolic, toxic, or hypertensive, you would use this other encephalopathy. Hypertensive encephalopathy is assigned to code I67.4, and this refers to transient neurological symptoms which occur due to elevated blood pressure. And last, we have unspecified encephalopathy, is G93.40, encephalopathy unspecified. Now, if you see encephalopathy unspecified, it might be advantageous for you to send a query to the physician to get a more specific type of encephalopathy, since that's a very broad term. So we have a coding clinic regarding encephalopathy due to sepsis, and this is from second quarter 2017, pages 8 and 9. How is sepsis-associated encephalopathy coded? And the answer is G93.41. Metabolic encephalopathy is used for septic encephalopathy. And if you look in your coding index, you'll see encephalopathy, and under there, you'll see septic, and that's the G93.41. When the type of encephalopathy is documented, assign the more specific code. use encephalopathy unspecified G93.40 if the type of encephalopathy isn't documented. We also have another coding clinic regarding toxic metabolic encephalopathy due to hepatic encephalopathy. And this is from first quarter 2022, pages 52 and 53. And the question here is, how do you code toxic metabolic encephalopathy due to hepatic encephalopathy if no toxic substance or medication is documented? And the answer here is to use K72.90, hepatic failure, unspecified, without coma, and G92.8, toxic metabolic encephalopathy. And the toxic in this case refers to the toxins generated from the body instead of outside toxins. The toxic metabolic encephalopathy code has a code first directive, and in this case, the underlying cause is the hepatic encephalopathy. So let's move on to another coding scenario. And our question here is, a 45-year-old patient has been on antibiotics for UTI, developed altered mental status, and was admitted to the hospital. Final diagnosis was toxic encephalopathy due to ciprofloxacin. How would this be coded? So I'll give you a few seconds here to look up those codes. And our answer here would be G92.8, other toxic encephalopathy, and the T36.8X5A, which is an adverse effect of other systemic antibiotics, initial encounter. So since this was considered an adverse effect of a prescribed medication, you're going to use the adverse effect code. So let's move on to delirium. So what is delirium? Delirium is a serious disturbance in mental abilities that result in confused thinking and reduced awareness of the environment. So what are some symptoms of delirium? Seeing things that don't exist or hallucination, restlessness, agitation, or combative behavior, calling out, moaning, or making other sounds, being quiet and withdrawn, especially in adults, slowed movement or lethargy, disturbed sleep habits, or reversal of night-day sleep-awake cycle. So what are the types of delirium? We have mixed origin of dementia and other, and that's code F05. Delirium due to known physiological condition. Post-procedural, which also codes to F05, delirium due to known physiological condition. Puerperal, F05, delirium known physiological condition. Superimposed on dementia, code F05, delirium due to known physiological condition. Delirium tremens, which is code F10.231, alcohol dependence with withdrawal delirium. And other unspecified delirium, which codes to R41.0, disorientation unspecified. So basically, other than delirium tremens or unspecified delirium, you will be using code F05. And we have a coding clinic on coding delirium of unknown etiology, and it's from second quarter 2019, page 34. And our question here is, how do you code delirium of unclear cause? Code F05 is for delirium due to known physiological condition. And the answer here is you code R41.0, disorientation unspecified, would be the correct code for delirium of unknown cause. So basically the R41.0 is more of a symptom code, but that's what you would use, the disorientation code. Okay, let's also talk about altered mental status and confusion. So what is altered mental status? Significant changes in mental status can occur without the patient losing consciousness. These changes often include various degrees of cognitive impairment. Many conditions initially manifest with a change in mental status as a primary symptom. Depending on the age and general health of the patient, there are a wide variety of potential underlying causes of this symptom. In pediatric populations, neurological disorders, trauma, shock, metabolic disorders, poisoning, and CNS infections are the most common. In the elderly, mental status changes are common effects of medication, electrolyte imbalances, or infection. A change in mental status is often noticed by family or caregivers, with patient unaware or reluctant to seek care. Altered mental status is reportable when it cannot be attributed to an underlying cause, or if there is no other diagnosis or condition for which mental status changes are an integral part of the disease process. So what is confusion? Confusion is the inability to think as clearly or quickly as you normally do. You may feel disoriented and have difficulty paying attention, remembering, and making decisions. So how do you code altered mental status or confusion? For altered mental status, you will use R41.82, altered mental status unspecified. And for confusion, you will code R41.0, disorientation unspecified, which is the same code you use for delirium unspecified. So let's move on to our last coding scenario. Our question here is, a 65-year-old male is admitted with confusion. Patient is a known alcoholic with a history of 20-year dependence. Final diagnosis is delirium tremens. How would this be coded? So I'm going to give you a few seconds here to try out coding this one. And our answer here is F10.231, alcohol dependence with withdrawal delirium. And there's also a note under this code that you may also add an additional code for the blood alcohol level, which is in the Y90 category, if applicable. So if the physician does happen to document the blood alcohol level, you can add it under this code. So let's talk about some treatments for these conditions. And primarily it is going to be medications used to treat mental function, balance mood, and lower blood pressure. And we have memantine, rivascamine, galantamine, and donepezil. I'm sure I probably butchered those, but I'm not exactly sure how to pronounce them. But those are the 4 primary medications that they use for these conditions. They may also give the patient occupational therapy, which is used to improve the work and daily living skills, and rehabilitation, which improves mental and physical functioning. So in conclusion, if documentation of confusion or altered mental status is mentioned, look for an underlying cause such as dementia, encephalopathy, or delirium. When coding dementia, look for a type, such as Alzheimer's or Parkinson's. Alzheimer's disease can be further clarified as early or late onset. Remember that Parkinson's dementia and dementia with Parkinsonism are coded differently. When coding encephalopathy, look for the types such as metabolic, hepatic, etc. Some types of encephalopathy can be coded together if both are present, such as metabolic and hepatic. When coding delirium, look for the types such as post-procedural or delirium tremens. There is a coding directive with delirium code F05 to code the underlying physiological condition first. And as always, when in doubt, queries are helpful. So just remember, it's important to be as specific as possible. You will want to, if a patient is shown as dementia, you will want to look for the type, or the same for encephalopathy. And if you have delirium, you will want to code the physiological condition first. And queries can help with all kinds of problems with documentation, and with these specific diagnoses, they are very helpful. So I have a list of our references here. And I want to thank you for joining me today, and I hope you enjoy coding.